I'd like to welcome everybody to this MAX webinar. This is the fourth MAX webinar. For those of you who are providers, you should be aware that you can sign up for help through MAX as we provide consultation service related to addiction. And the website you can see on the screen in the first slide. The purpose of the consult service is a free service to help with clinical questions related to treatment of substance use disorders, and we're actually expanding to questions related to chronic pain management as well. We offer help with clinical questions, linkage to resources, education training opportunities, and if you're not sure whether your question is something we would help, just go ahead and send it in and we can figure that out later, but we really are here to assist you. So my name is Michael Fingerhood, and the topic for today is treating opioid use disorder in a primary care setting. This is something I've been doing for quite a while, and I hope you get my message of passion for doing this. I have no disclosures, again, except the strong passion for integrating addiction treatment with primary care, and I hope to convince you and for you to see why I'm so passionate about this topic. So the objectives are to increase knowledge of epidemic of opioid use disorder, to increase knowledge of treatment of opioid use disorder, and to convince that integrating treatment, in this instance, we're talking specifically about opioid use disorder with primary care, is beneficial on multiple levels. I should say that I'm going to try to end a few minutes before 1, so there'll be 5 minutes for questions in which you can type in your questions even during the webinar, and then I'll try to answer some of the questions at the completion of the webinar. So I always find my attention span is best at the beginning, so I first want to lead off with why we're doing this and the types of patients I've seen, and these are all real patients. First patient is a 72-year-old woman that I saw for her initial visit. She had a history of chronic pain in her hips and knees. She was actually seeing a geriatric provider, and the provider would no longer prescribe oxycodone, as for the past 2 months, her 30-day script ran out after 2 weeks. She was open and knew this was true, but she was tearful and fearful that providers won't help her. She was unable to take anti-inflammatory drugs, and she was open that she often takes oxycodone when she's upset. She lives alone in senior housing, 2 daughters that weren't the best support, both with difficulties. She didn't smoke, no alcohol. After spending time building rapport and making sure she knew my goal was to work with her and make her quality of life better, I explained I would not prescribe her oxycodone, and I think she knew that. She was open to undoing isolation, and we talked about options, and she was open to trying buprenorphine. Almost immediately, she was physically more active. She no longer dwelling on when her next dose of pain medication was, and did she have enough. She had spent probably every few hours counting the pills in her bottle she had left for the month. She's remained on low-dose buprenorphine with actually very good pain relief, never running out before she should, and just incredibly improved quality of life. The next patient is a retired nurse who had right total knee replacement complicated by joint infection, requiring prolonged course of antibiotics, hardware removal with spacer, and finally replacement of her hardware. She'd been on oxycodone for 4 months, 15 milligrams 4 times a day. She had not seen me for quite a while, but she saw orthopedics in follow-up, and at that visit was told she should not be on any further opioids, as she's now 2 weeks out since her last surgery, and she's told to take ibuprofen. I just want everybody to realize that I made these slides before a warning came from the FDA I received in the mail last week, emphasizing the fact that patients like this who've been on long-term oxycodone, that this should not happen to them. And sure enough, I received a call from the police that KL had died from an apparent opioid overdose. I found out from her son that she had gotten into severe opioid withdrawal Actually, her grandson had bought her opioids on the street, and she had died of an overdose. So as we talk about opioid use disorder, I would offer to you that this is a patient who died of an opioid overdose who did not have opioid use disorder. Patient 3 is a 28-year-old woman seen by me for her first visit. I was able to review in CRISP, and I hope everybody uses CRISP, so the PDMP, that she had multiple ER visits for back pain, 1 opioid overdose, and many fill scripts with oxycodone from many providers. She had abnormal PAP previously, history of HIV, that she really was not engaged in care, hypertension, elevated blood pressure that day. She came in saying that she wanted a prescription for oxycodone. My agenda was getting engaged in medical care, and with that, hopefully treatment for opioid use disorder. So a lot depends on making agendas meet. She was open, and as we discuss, the conversation of how we engage patients will be part of what we talk about. But after 3 months, I'd seen her 7 times. She was doing well on buprenorphine and naltrexone. She had no back pain, and she was open about the fact that she realized that she had opioid use disorder once we got to know each other. Her urine drug screens were all negative since the first visit. She was on medications for hypertension, inherent with heart for HIV. She had PAP done, no ER visits. And then, importantly, better self-esteem, better relationship with family, and she was working part-time. So this is an all-encompassing goal of what we try to do, and the beauty of doing this in the primary care setting. So this is a little bit about me. Early on, people always ask me, how do you wind up doing what you did? I'm from Brooklyn, New York, and in 1974, in the building that you see, a methadone maintenance program opened. This was just after the Vietnam War. It was a wave of opioid overdose deaths at that point, not quite to the magnitude we're seeing today. And methadone treatment programs came to be in a fair number of neighborhoods in New York City. The reason it was especially something that provoked thought for me was I actually lived in this apartment building. This is 10 years later, and this is in the Bronx. This is a picture of Jacobi Hospital. And this is where I did my medical school training. And in 1984 was the next wave of health problems related to addiction. That was HIV. So in 1984, I did my internal medicine training for 12 weeks at Bronx Municipal Jacobi Hospital. And the admission board said this on the board. And many people today don't know what it stands for, but it was a stigmatizing term, shooter with a fever. And that's how patients were identified. So these are all people who had fevers related to injection drug use. Much like the wave we're seeing now in the past year on our console service. I probably haven't seen as many individuals with endocarditis or injection drug use related fevers since that time. But it was a derogatory term, and people didn't even go by their names. They went by the term SWAF. And this is just to raise the point in that stigma and prejudice play a huge role. And I think it's even played a role in terms of how people view taking care of patients with addiction. I've had people at community health centers say, we don't have people with opioid use disorder on our site. And that's because they're not looking. Remember, anytime we've prescribed an opioid for a patient, it's likely that at some point in our career, we've created someone or taken care of someone with opioid use disorder. My message is to recognize it and to be able to treat in the same setting where we see it, and to take away the stigma and prejudice. Labels are important. The other aspect of what triggered my career was when I was there, I remember asking, as we admit patient after patient with a fever related to injection drug use, why aren't we really addressing the problem? And the message I received from a well-meaning attending physician, I was a medical student, was that addiction isn't a medical problem, and that as physicians, it's not something that we can address. Everybody who's listening to this webinar, I hope realizes that this is a medical disease and we have to address it in a medical way. So related to stigma, I'm going to just give us a couple sidelights. This is a shower, and this is the way you get clean. So for all my patients, I correct them. So it's ingrained. If you go to Narcotics Anonymous meetings, that people say I'm clean. It's a terrible term to think that we refer to people who are using, who have opiate use disorder, that they're dirty versus in recovery. So dirty and clean is something I always discuss with my patients in the primary care setting, and eventually they get it right to let me know that they're doing well in recovery or they had a slip, and not that they're dirty or clean. This is the term that I use in my mind whenever I see someone who initially comes for care. So in the midst of addiction, as we look at what happens during addiction, this is probably the best adjective, or really a noun to think about how people feel, right? So they're just full of despair. There's not quite a synonym, right? It's a sense of, I don't know what to do, I feel lost, I feel ashamed. And the reason I have a picture of the scream there is the original name of the painting actually was Despair, as Edwin Munch, who painted it, was actually someone with alcohol use disorder, and it was believed that it was actually a self-portrait of how he felt as he struggled to try to get sober. So I'm going to give a few background slides on the idea of integration. So in 2006, 13 years ago, the Institute of Medicine released a report recommending improvement in coordination of mental health and substance-related services in general health care settings. And again, 13 years ago, available evidence suggests that integration of mental health and primary care may lead to improved care and quality of life, and that studies of health delivery, process of care, and health outcomes in integrated clinical settings will be critical to inform the process. I'll present you some data to show some of the work that we've done to show that the outcomes are improved. A few years ago, I undertook a study with some medical students, and we decided to do a qualitative interview. So we interviewed 20-something patients and did long interviews, and then we categorized themes from what patients said. And so there are two things that I think, as we're talking about integrated care, is to think about. The first is, what should providers expect from their patients with addiction, right? So if I'm seeing a patient, what should I expect from that patient sitting with me? And the two major themes were desire to receive care that will improve health, and engagement in care based on trust and rapport. And this is the flip question is, what do patients with addiction need from their providers? So this is what the patient needs: a knowledge about addiction, a duty to treat, which I think is something that's pretty strong, and I don't know that all providers realize, and that's certainly part of being a physician. A focus on overall health, which is a theme of I want them to focus on all of me, to engage patients in care. And then I think most importantly, this last statement, which was the most common theme, to treat the full scope of illness. And these are patient words: isolation, rejection, and creating hope. It's only going to brief touch on the fact that the costs are huge. 2016, it was thought that there were 25 million people currently using illicit drugs. That doesn't even estimate how many people ran into problems through prescription opioids. A vast majority of individuals not in treatment. That's still true in 2019. Huge economic burden. The total here says $524 billion a year. It's probably more than that. And then you can see data specific for opiate analgesics were about 4.5 million, and 700,000 used heroin in the past year. Those numbers the heroin numbers are pretty constant, although includes fentanyl. And as is known through much of the media reports, that drug overdose deaths are higher than deaths related to motor vehicle accidents. So this brought a lot of attention. This was when carfentanil hit the United States in 2017. It seems to have fallen down a bit. That in 2018, I don't believe in Maryland there were any carfentanil deaths, but it's meant to focus on the fact that most of what people are buying on the street are fentanyl analogs. It's not heroin. We recently had a presentation from the DEA. The cost per kilogram of fentanyl product that's sold on the street of Baltimore is 1/3 of that of heroin. So in general, almost everything on the street is fentanyl based, and in fact the prices are lower as a result. So part of that unfortunately gets passed on the consumer. So most gel caps in Baltimore now are $6. The same things that used to be $10 when they were heroin are now $6. Just to quickly to spend 2 minutes, strictly speaking, we often interchange opiates and opioids, but opiates are naturally present in opium. That includes morphine, codeine, and thebaine. And opioids are manufactured, and they can be semi-synthetic or synthetic. Semi-synthetics are heroin from morphine, buprenorphine, oxycodone from thebaine, and then synthetics are completely man-made, and that includes methadone and fentanyl, which we're facing an epidemic related to. Just a comment on narcotic regulation in the U.S. Really, the most important aspect to realize was the Harrison Narcotics Tax Act of 1914, and what that did to medical practice was that since 1914, that if a patient showed up in a physician office and said, I'm using morphine or heroin and I need help, you could not prescribe another opioid in order to help the patient ease through withdrawal. So most patients still are not necessarily aware of that, but it means before that, someone comes in, you could say, I'm prescribing you a tapering dose of tincture of opium or liquid morphine. So since 1914, that was not allowed. In 1925, there was a challenge saying that Congress shouldn't regulate medical practice. It was a mixed outcome because the practice didn't change, even though physician Linder won. So there was no real ability to medically help someone with opioid use disorder until the 1960s, when methadone was introduced as an experimental treatment for opioid addiction. And then soon after that, there was the Bureau of Narcotic and Dangerous Drugs, which created specific rules for methadone, and this became the DEA in 1973. I just want to review quickly just DSM-5 criteria for opioid use disorder, mostly just to reflect on the patient. So it's no longer abuse versus dependence. And there's 4 groups, and it's related to impaired control, social impairment. You can see that the pieces, risky use, and pharmacologic dependence. And you need at least 2 to qualify for even mild opioid use disorder. I want to point out again that the lady who had a failed knee replacement, who then went into withdrawal when her pain medication was stopped, had pharmacologic dependence. So pharmacologic dependence is inevitable if someone's on opioids for any amount of time, but that she otherwise had no other criteria for opioid use disorder. So there had to be something in those other groups in order to qualify. So how do we identify patients in the primary care setting? Easiest way is to ask or discuss. There are screening tools, and electronic health records are not the best. We have Epic where we are, and it doesn't really have good criteria or good ways to screen. So I think each person who's doing it will have to figure out their own way, perhaps. Certainly clinical assessment helps. The medical record and history helps. Using CRISP and PDMP, as I showed in the patients, the one patient, I do it for every individual as I'm seeing them. I review their records in CRISP and TDMP. In Maryland, there's an ability to actually search a criminal record. I don't necessarily advocate that, but I have to admit at times I've used it, and you can because it tells you about arrest, but not necessarily circumstance. But occasionally I've had patients who do come and ask for opioids. I see something in emergency room, multiple emergency room visits, and I have actually looked to see if there's been criminality related as well. So many electronic health records or algorithms in a variety of clinical settings use SBIRT, which stands for Screening, Brief Intervention, Referral to Treatment. I always ask in public talks where SBIRT works best, and the answer is primary care. There's multiple papers that show intervention in the primary care setting is the most effective, especially for things, for instance, in terms of hazardous drinking or alcohol use disorder, to show actually the biggest impact in the primary care setting, and that goes for in general as well. There's some recent papers looking at effectiveness, for instance, for an inpatient hospital addiction consult service that show limited impact, but that doesn't mean you shouldn't do it, but rather that, again, the greatest effectiveness is in the primary care setting. So, but my bias actually, and the theme perhaps of the webinar, is that in the primary care setting, we should be doing SBIRT, we should be doing screen, intervene, or treat, or some people have said assess, intervene, and treat. It means that you should be able to make an assessment. And the obvious piece that's left out is the R. There are many studies to show that when care is siloed, that it's very difficult to get that R to happen. There are some studies to show it happens in most studies less than 10% of the time. So what do I say to patients in terms of building rapport? I say to them, I ask them about their support system, because that's part of the conversation as I get to know patients anyway. And I ask them about who's their fan club, who's their support system. And I use the term fan club to find out about the support system and to let them know that I've joined your fan club. And should be in the background, right? So intervention and education are effective, that we emphasize health and relationship benefits. If possible, I try to use family and friends in a positive way. I never use threats, which commonly happen in the emergency room, most likely. If you use, you will die. If you drink, you will die. But we spin it. So we give hope that life can improve, and we talk about what things can improve. And I acknowledge reasons for use, right? So people use opioids because they get euphoria and they get high. And I openly acknowledge that. So I know you like to, you like the effect of opioids. That's always going to be true. But what things can get better, or what benefits would there be, despite the fact that you like to get high? What would the benefit of you? What would be your benefits of getting some recovery and making a change? So the traditional approach for opioid use disorder had been 12 steps. I have only 7 here, but it's really a focus on a surrender to a higher power, a commitment to abstinence, a sober social support system. And these are all important, but for most patients, they aren't enough. So I want to emphasize again, despite many documents that I'm not going to talk about detoxification, but detoxification is not treatment. And many traditional Narcotics Anonymous groups encourage individuals to go get detox and then come back. If you look at most studies of how effective that strategy is, it's less than 10%. Some studies, perhaps 5% of patients can have any success with that type of strategy. So again, detoxification is not treatment. So the rationale for opioid replacement therapy is multifactorial, right? So it's basis on stabilizing neuronal circuitry, that you put something on the mu receptor, and therefore if someone tries to use an opioid, that they don't get high. So as a result, you prevent withdrawal and craving. And obviously, if someone's not injecting drugs, they won't spread HIV and hepatitis C, nor commit criminal activity related to drug use. So I'm only going to talk briefly about naltrexone. This is the only slide. So naltrexone is a pure opioid blocker. It's available orally and as an injection. Overall, the acceptance is fairly poor. It's very tough to get someone past 1 injection. It certainly works as part of contingency management. do research studies related to contingency management, but even there, the acceptance is pretty low. So that we have people have to enter a workplace and get paid, and in order to do that, they have to accept the injection, and the fallout is very high. And there's really little evidence for long-term efficacy. So a little over 21 years ago, NIH had a consensus conference on the effective treatment of opiate addiction. And it said that opiate dependence is a brain-related medical disorder. Treatment is effective, although a drug-free state represents an optimal treatment goal. This is again in 1997. Research has demonstrated that this goal cannot be achieved or sustained by the majority of opiate-dependent people. And to reduce unnecessary regulation of long-acting agonist treatment programs and improve the training of healthcare professionals in treatment of opiate dependence. So certainly timely now. So I find these these are old studies from the 60s by two of the pioneers in opioid treatment in New York, Nicewinder and Creek. But I think it's useful to point out that when someone is in the midst of using opioids, the majority of the time they're either high or sick. And if you notice, they spend very little time feeling with the term they used then, which was straight. And remember, everybody who wakes up feeling sick. So I point that out as a useful tool because it's a way to have a conversation. Wouldn't it be great to wake up not feeling sick? My other bias, and I've had a hard time with this battle, is that we need to avoid using the term MAT, although it's throughout the government literature, it's throughout SAMHSA literature, and that it's medications. That medications for opioid use disorder are the focus of treatments. And that we don't say that when someone has type 2 diabetes and they haven't gotten their hemoglobin A1C better with diet and exercise, sorry, it's time to start MAT. And that we say we're starting a medication. And I think it's unfortunate that we use that term, and I think the term perpetuates some of the stigma that we'll talk about in a few minutes related to using medications for opioid use disorder. We don't think people have failed if they have to get on metformin, but sometimes there's a perception that if someone needs to be on medication for opioid use disorder, that means they failed. And some of that, unfortunately, is from 12-step meetings. So this goes back to what happens when someone is on medication. So this is from the same group, and it showed that if they received a dose of methadone, that they won't wake up sick. One of the dots just shows that if they didn't get dosed again, that they would feel sick. And in one instance, they used heroin to and really didn't boost much because the receptors were already taken up. Again, early studies looking at methadone. This is at the start of the HIV epidemic, where people were interested, well, how much will the use of methadone decrease people using drugs by injection? But what I think is useful here is to realize that we've, to date, usually think of methadone as the gold standard. But even at the end of 1 year, about half of people are still on occasion using injecting an opioid. And then even as we go out, there's still people who occasionally will still inject opioids. So I think the message here is to realize, even as we see patients on buprenorphine, to realize that, well, if someone has a slip, we should resist the inclination that we need to push that patient over to methadone instead, realizing that people on methadone have slips as well. And this is old data to show that we have to reset our expectations. So since 1914, we've been unable to do anything, and finally in 2000, the data was passed, bipartisan bill, which said that qualified physicians could treat opioid dependence outside methadone facilities, again for the first time, and gave the rules. And at this time, it was an 8-hour course from approved organization. And as a result, you received from the DEA new DEA number, your regular number now with an X in front of it, to use medication for opioid dependence. That was the wording. And as of today, only one medication formulation is approved for this use, and indeed that is buprenorphine. I don't have additional slides, but most of you should be aware that DATA 2000 was amended 2 years ago to include the ability for physicians, assistants, and nurse practitioners to prescribe buprenorphine as well. Unfortunately, there's still some states in which those individuals cannot receive a DEA due to state rules. The training is 24 hours instead of 8. And in addition, in the past year, the nurse anesthetists have been added as qualified as well. The number of patients has also changed. Initially, it's 30, then it's 100, and now after in the past year, two years ago, with the amendment, it was increased to 275 patients per provider after that year. So these are criteria just to compare. Most importantly, the difference for buprenorphine was age 16, that the prescription is filled in a pharmacy, and that there's no time criteria. So for methadone, there was a time criteria for 12 months. Buprenorphine, there is no time criteria. So someone who ran into difficulties 3 months ago and needs help, buprenorphine is an option. This was one of the first papers that was published in 2000 in the Journal of Medicine. It looked at under research conditions, so not real life, not clinical care, that at 17 weeks, high-dose methadone retains 73% of individuals, while buprenorphine, median dose of about 16 milligrams, retained 58%. LAAM is no longer on the market. So what about buprenorphine? Buprenorphine has modest mu agonist activity with a ceiling. It has a long half-life. It has precipitated withdrawal if taken after a full agonist because it has a stronger affinity for the receptor than other opioids. It's administered sublingually, and the combo tablet with naloxone limits abuse by injection. Naloxone that's in the tablet under the tongue is not otherwise active. You can get very low doses if you look, but it's otherwise not active. In terms of safety, no alteration of cognitive functioning. Patients feel normal. No organ damage. There was early concern for hepatotoxicity. That's really been unconfirmed. I've treated patients with significant liver disease as well without a problem. There's no evidence of QT prolongation, which is often a concern for methadone. On our inpatient consult service, it's not unusual consult for someone who presents with Torsade from methadone that we work to get transition to buprenorphine. The ceiling prevents respiratory depression and as a result, overdose. Any overdose reports that are in the literature are polydrug overdoses and not related to buprenorphine itself because it does not cause respiratory depression. And there's no clinically significant interactions with other drugs, which makes it quite useful. So I'm going to say to stop using this term. It's especially an obstacle in most primary care settings where this is induction. I think it was a mistake. I fault the original writers of the SAMHSA tip on the use of buprenorphine because it makes it seem like there's something difficult. It creates obstacles. We have settings where we'll say we'll take a patient on buprenorphine, but we won't induct them. So that's pretty alarming because for most other health problems, we would never say that. This slide is obviously called starting buprenorphine. We do it at home when we see patients. We provide coaching. It's no different than starting blood pressure medication. You may need some titration. Certainly much easier than starting insulin and safer, right? So just think of how difficult it is to start insulin in terms of technique and everything else that has to be done, making sure you give the right dose, even regardless of the sterile technique. Strong counseling on taking the first dose once in withdrawal. I'd say the majority of patients actually know this. And when somebody says, I think I had an allergic reaction to buprenorphine, it's because they precipitated withdrawal. they took a dose too soon after another dose. And generally, we increase the dose up to 16 milligrams by the second day. Usually I tell people to take the first dose of 4 milligrams, another 4 milligrams that evening, and by the second day to take 8 milligrams in the morning. We do mostly phone check-ins. On occasion, if I'm concerned, I'll see somebody later that same week. But the majority of patients, we do phone check-ins. Someone in the office calls. Early on, I didn't have peer recovery coaches, but I do have peer recovery coaches now in the office, but a nurse or even a medical assistant to call in just to check in if there's a problem involved. But 90% of the time, it works successfully without the need for a primary care provider to have a conversation from those phone check-ins. But don't I need to provide a counselor? So you saw on the slide, I mentioned that it said that counseling services should be available, but the answer I'm going to show you is that the answer is no. The hope is, though, that as a primary care provider, that you're skilled in motivational interviewing, right? So all of us have a goal of helping our patients live healthy, eating healthy diets, getting exercise, and the same conversation or motivational techniques we would use for those other things should be the same in this circumstance. I'm only showing you one study, but there are many looking at whether or not providing standard medical management with buprenorphine or standard medical management plus requiring counseling makes a difference. And this is just one paper, so you have a reference, but separate counseling did not change outcomes. So are there patients that we perceive outside of a clinical trial that need additional help? Of course, the answer is yes, but requiring counseling is not something that has, in any study, has been shown to be an effective strategy. And again, I just remind people of another pharmacotherapy, and this is looking at, this was published in JAMA, looking at pharmacotherapies for alcohol dependence, the combined study, which looked at pharmacotherapy that could have consisted of acamprosate, naltrexone, placebo, and whether provided counseling in the office versus outside counseling. And the only arm that was useful for naltrexone was if naltrexone was received in the primary care setting without referral to outside counseling, meaning that the primary care provider was providing the motivational interviewing, and that, in fact, that if you referred someone out, they did no better than placebo. So very frequently we encourage individuals to go to support groups, and that's tough because a message frequently heard in 12-step meetings is you're not in recovery if you're on medication. I warn patients about that statement. It could be in support groups, it could be from family members. I tell patients to be careful about who they tell because they're going to get negative messages that are incorrect. Patients often self-stigmatize as well, thinking, you know, I know somebody who's been in recovery for 5 years, they didn't need medication. So I always have a conversation validating that that the medications are there and obviously provide success. So these are quotes from patients. I feel normal, I wake up not sick, I have my life back. I've been doing this for over a decade. I take care of many professionals with opioid use disorder. I take care of many people who went back to school, people who send me pictures of them graduating college or even getting a master's degree after suffering from just terrible opioid use disorder. By doing it in the primary care setting, we're also legitimizing opioid use disorder as a chronic illness, just like any other. It's also a great way to build a relationship and show partnership with patients as well. I'm showing this slide just for a message. So this was published in JGM 2005, some of the early data. In this study, again, about 59% of people at 6 months were doing well on buprenorphine, again, in the primary care setting. But the top line, the solid line on top, shows that if your urine drug screening for opiates was negative at 1 week, you were 80% likely to still be engaged in care at 6 months. So it's dramatic. So the message I use, it's tough to know if you can change who those people are or they self-declare. But the message is that I try really hard in the first week. So that's why we have people call and check in with them during the first week. And when someone is opiate negative already at the first week, like I presented the lady who was not engaged with HIV, that she was negative at 1 week, and sure enough, she did really well, and she's remains in recovery. This is a study that we did in the same building as a methadone treatment program, and we're on different floors. We're sort of in the same building. And we just looked in the same time frame, people who sought care with us for integrated care for buprenorphine in the primary care setting versus people who received methadone treatment in more siloed care. So it's not randomized, it's people self-selecting. But I just thought to give you an idea that differences, the ages were pretty similar. There was some gender difference. So I want to highlight the fact that we see a lot of patients with commercial insurance. So remember, opioid use disorder, lots of people who work and have jobs and have commercial insurance who need help. And you can see in this initial study, we had 45% of our individuals employed versus only 13% in the methadone program. This is just meant to say that it's great that we have two different treatments. We shouldn't say one is better than the other, but I think we are reaching different patients, and that we need to provide this in primary care settings because our patients aren't going to wind up going to a methadone treatment program. And these are just the other characteristics as well. You can see that even though in the primary care setting, pretty equal numbers that we're using heroin, cocaine pretty similar as well, less benzodiazepine use, which I think is important for you to realize. I think that number is even smaller. Of the patients I treat now, I say that only less than 5% have a history of any misuse of benzodiazepines. And then you can see the other numbers as well. From that same study, we looked at percentage of patients who are in treatment each month and percent whose urine drug screens are opioid negative. And we went out to 12 months. The useful piece is perhaps look at the end and the beginning. So at the end, buprenorphine and methadone were fairly similar. There were no statistical differences in retention or the percent of urines that are opioid negative. But what you notice is that for buprenorphine, the biggest dropout was in the first 2 months, and then things kind of come together. Methadone certainly is tougher, right? Once you start, it's tougher to stop because you're going to have withdrawal. With buprenorphine, the fall off early on is perhaps more likely to happen. And again, it means that individuals in the first couple of months do need more support. And then I want to point out a recent study that we published in Population Health Management, which looked at Medicaid patients who received a script for buprenorphine between 2008 and 2012. So this is more recent than the patients that I just showed you, where our retention rate was about 58%. In this instance, only first episodes were analyzed. Again, Medicaid patients. And we compared, CCP is the practice I have where we provide integrated care. It stands for comprehensive care practice. And the non-CCP were patients receiving buprenorphine not integrated with primary care. And I want to point out our 6-month retention was 80% versus that similar 59% for other patients. Most studies of retention of buprenorphine in siloed care are between 55 and 60%. I want to point out that number is still excellent, especially when you compare efforts to help someone quit smoking, that you perhaps get 10 to 15% of patients to quit smoking at 6 months. And then you can see that a big message on the bottom was that providing integrated care is cost saving and less expensive. That total cost includes the cost of buprenorphine. And I'd like to point out it's likely that the cost savings will increase after 12 months because in that 12 months are things like screening tests, testing for HIV, hepatitis C, more lab tests, mammograms, pap smears are all part of that total cost that the patients who were not receiving integrated care most likely did not have done. We did sub-analysis even looking at, for instance, hospitalizations, even though it was non-significant. the costs of hospital stays were much greater in patients who received silent care versus integrated care. So I hope that maybe I convinced you that you should prescribe buprenorphine in primary care setting. And now I just want to spend about 5 to 8 minutes on the conversation and the art part of taking care of patients with opioid use disorder. I'm just going to get back. So, and I'm going to get back to the questions. I'm going to make sure I leave time. I'm going to go through the questions. So the themes that you'll hear from patients and that I bring to the forefront is that when patients come to you, that there's a lot of shame. And much of the conversation often happens on how we can undo the shame. And clearly related to shame is this type of conversation. Self-esteem. The best thing you do for yourself is stop using drugs. Patient, I don't deserve the best. What else can I do? So I think that we acknowledge that's where patients are. And a lot of the conversation is about how can we make yourself feel better about yourself. And it's easy to realize that as conversations happen and visits happen, all of a sudden eye contact is better. Patients present in a different way. So shame and self-esteem are conversations that I bring to the forefront. And then coping. And I let patients know that this is forever. I don't want patients to have a slip, but we try to anticipate them. Are there stressful moments in your life where you feel more vulnerable? Many of our patients have a history of intimate partner violence, have witnessed violence, have had trauma, and eventually those conversations happen. And we also anticipate events that might make it more difficult. And we talk about coping skills. And we talk about a wide range. I let patients suggest it could be related to exercise, yoga, meditation, friends in recovery. We find what supports are out there to help with coping. So some of the visit openers that we have or that I have with patients as I get to know them, they're usually pretty positive. What have you done today to make the world a better place? We talk about saying good morning to strangers. And this is how I define recovery, and I'd let patients know this. Recovery means making today better than yesterday. It's a pretty simple definition. It's not based on days. It's what have you done to make today a good day? And then when patients have achieved some success in recovery, I then say, give me an update for your fan club. So these are some what ifs. My patient's urine drug screen is positive for. I always remind that buprenorphine is a treatment for opioid use disorder. It doesn't mean to say that I won't treat someone if they use other things, but it's not a treatment for cocaine. It's not a treatment for benzodiazepines. But by prescribing it and they're not using opioids, first remember they're not going to overdose. They're not going to die. I'm going to decrease their likelihood by a great extent of having an opioid overdose, that they're starting to put their life together. I have many patients who gradually over the first year realize that they have stopped using cocaine. I have multiple patients who still dabble in cocaine, and as we get to know each other, I think that they're honest, but it's not unusual for some to say, I still unfortunately use cocaine once a week. And we work on it. It doesn't mean I'm not going to prescribe them buprenorphine because they're using cocaine once a week. My patient's drug screen is negative for buprenorphine. Most urine drug screens you should check for not only buprenorphine, but norbuprenorphine, which is the metabolite. It means to bring a conversation. At times I check the PDMP. I ask them to bring if they're on a film, I ask them to bring the foil from the film with them in their follow-up visit. I do use a patient agreement for all patients. There are a variety of different patient agreements. I encourage you to use a one-page one. After this webinar, if you want, we can also and you provide an email. I can certainly share with you a sample treatment agreement. It's meant to be let's work together, not here's how I'm going to catch you. Patient misses an appointment. I don't always create rules. The treatment says that you need to make your appointments, but I certainly would not say you missed your one appointment. I provide flexibility. I like to make contact with patients. So personally, I don't necessarily like to have a lot of lab visits where people just come to give a urine, because I prefer having a conversation, even brief, where if my schedule is really full and I know I want them to go in for a urine drug screen, I ask them my staff to make sure that I at least have a 2-minute conversation with the individual when they arrive. My patient asked for a refill early. The treatment agreement says that medication is going to be given as prescribed, then leads for a conversation. And then finally, my patient has an overdose. Unfortunately, this happened to me once in the past year, where I then found out from family that someone had dropped it, who had not seen me and missed an appointment, that they had an overdose. Patients who have buprenorphine in their system are much likely to have an overdose. I let patients know that. And in fact, we want lots of naloxone out there, but if someone is found who has an overdose and you don't have naloxone, but you do have buprenorphine, that there's a chance by putting it under their tongue that you can actually reverse the overdose, because you're going to be precipitating withdrawal. Again, a reminder that recovery is about progression, not perfection. Patients will have slips. There'll be vulnerable times, and I call them slips rather than relapse. And these are some of the pieces. That there's a lot of pieces to how recovery happens. Our most important aspect is giving patients hope, and then we can work with them for those other pieces. But as primary care providers, hope is essential. So we have about 5 to 7 minutes now to answer questions. These are Dr. Bob and Bill W., who I think are heroes. They normalize and destigmatize addiction by forming Alcoholics Anonymous and realizing that this can happen to any and all of us. I'm going to go through the questions that were sent through the chat, but I also want to remind people that after the webinar is over, that there'll be a survey for you to answer. So I'm going to go through the questions. I think there's enough time to go through the order. Please feel free to type in more questions as well. So there's a question: why does it take so long for the DEA and medical board to intervene regarding providers driven by money and trouble with the medical board? So you can directly report people to the medical board. Theoretically, you could directly report people to the DEA. I've done that on one occasion where I knew from another patient that there were people hanging out in long lines in the street trying to get benzodiazepines from a provider who's not taking a history or doing anything. So I don't tolerate individuals who, unfortunately, are, I think as a public health measure that we should report, and I encourage you to. I skipped one here. Someone asked, in multiple provider practice, you recommend everyone in the clinic being consensus about who to treat and how to treat. So I think there has to be some consensus. I think you need coverage, for instance, that if you go on vacation, you need other people who have X number who can prescribe or answer questions. I think you have to train staff as well. Early on, I remember there was a concern, what will people look like in the waiting room? In my waiting room, you can't tell. I take care of a faculty member who's seeing me for primary care versus someone who's here to receive integrated care for buprenorphine. But I think you want to have some consensus that this is an effective medication, because you don't want people talking behind you about whether or not they believe this is an effective treatment. You don't want to hear people saying this is just a crutch, it's substituting one drug for another. So I think that you want people to be comfortable, and the easiest way to get comfort is by education. Talking to people in recovery is the most useful. So it's very useful for patients to share their story and to know that this is such an effective tool. Where's the other question? Oh, I'm sorry. Someone asked about, I didn't mention about Sublocade. I'm sorry. So Sublocade is a branded, and then I'll go up to, is a branded injection form of buprenorphine. So prior to this brand name, there was another rod form, almost like a Norplan, that was put in the arms, made by another company. That formulation was only good for a year. You put the rods in each arm for 6 months, and then you were done. So the new branded form, which is a 1-month injection, it's unclear how it's going to fit. So I think it can be of use. I plan to adopt it. So it has to be given as an injection with the person lying down. It's not stocked in pharmacy, so the actual getting it to the office is kind of the stumbling block, along with insurance coverage. So I think eventually it's going to be an effective tool to use. The cost is something that's in the package insert. It's $1,800 a month for a dose of Sublocade, or the injectable form of buprenorphine. Someone has to be stabilized on the sublingual form first. So I think the way insurance is going to cover it is, I think we'll know more within the next 6 months or so. Then there was a question, experience of insurance coverage for urine drug screen. The important message here is don't send the pain rehab tox, which tests for many things that you don't want. So most commercial insurances cover urine drug screens. I didn't touch on the fact as to whether or not you want to do points of care. In most settings, point of care testing urine drug screens are more difficult. There is some variation in terms of sensitivity and specificity. In most instances, there are some of the kits you have to test for presence of buprenorphine separately. But if you send typically what we send is the NIDA drug screen, which includes oxycodone now. And then we do have to request, unfortunately, fentanyl separately, which I've had a battle trying to get fentanyl included as the typical drug screen. To me, I've pointed out to the team in charge of our test that's like saying that during an influenza A screen epidemic, we're only testing for influenza B. But typically what we send is the panel, the NIDA drug panel screen, and then we ask separately for screening for fentanyl and buprenorphine as well. And the buprenorphine screen will include detection of metabolite. There also is available oral swab testing, although I find in clinical settings the oral swab testing is not as sensitive for presence of buprenorphine as it should be. Someone asked a question about OxyContin. So in general, remember, prescribing in most settings for opioids has been limited. In a hospital setting, I have a primary care practice on a Hopkins Bayview campus site, but in many settings, the number of pills that could be dispensed has been limited, especially for acute pain. So the initial prescription, depending on diagnosis, has now been limited to 3 days or 7 days. But I think that's an important aspect. But again, I want to emphasize that the current epidemic of opioid overdose does not mean that there should be no patients on opioids. I took care of a lady in her mid-70s with heart disease who needs bilateral knee replacement. She has some heart failure. She can't take anti-inflammatory drugs, and she takes oxycodone 5 milligram tablets 3 to 4 times a day, reliably, never misses. With that, she's able to get around with her walker. So I always like to, as we talk about integrated care and primary care setting, that does not mean that we should not be prescribing any opioids at all. I think so that worked out just right. So it's 1 o'clock. So I thank you again. As this closes, I encourage you to fill out the survey, and also if there are additional questions that I'm more than happy to provide email information as well.